dosing in the critical care setting, but the renal dosing that we'll discuss is used throughout the hospital. And then again, recommend an adjustment in a critical care patient, and then identify some other instances in which a clinical pharmacist may recommend a dose adjustment. So like I said, just for some context, I thought it would be helpful to discuss kind of where I work, because it is a little different than a lot of hospitals in the area. So I work at University Hospital's Portage Medical Center, which is located in Ravenna, Ohio, which as you can see is in Northeast Ohio. So we are a community hospital. We're 117 staff beds. So we actually just got upgraded from a small community hospital to a medium community hospital. We're a nonprofit. We're a level 3 trauma center and a primary stroke center, which means in critical care, I am very busy. We have a lot of stroke patients, and even though we are a level 3 trauma center, because of where we are, we're the only hospital in the county. For a lot of patients that live in the county and in surrounding counties, we are the only hospital within an hour to an hour and a half drive. So we see a lot of very critical patients that will come to our hospital, and then we will transfer them to one of our larger hospitals. So University Hospitals is, I believe, 21 hospitals now throughout 16 counties in Northeast Ohio. There's 50 health centers, which can be urgent cares, and over 100, I think actually it's more than 200 now, physician offices. So we're part of a much larger network. So we will get very critical patients, we'll get them as stable as possible, and then we will send them to our larger hospital up north. So very busy. So just a breakdown of the service. So something that's unique about my position is I actually do the intensive care and emergency medicine components. So usually in the US, you do one or the other, but I have the privilege of doing both. So most, like Dr. Sakar said, I did a PGY1. Most pharmacists in my position actually go on to do a PGY2 and specialize in either intensive care or emergency medicine. I lucked out that I was in the right place at the right time. And throughout my first year of residency, my residency program director, who actually was my mentor all throughout college, he also went to Findlay, knew that this was my goal and kind of changed my rotations around so that I could take on this job. But I get to do kind of the best of both worlds with both services. So in each of those settings throughout the day, I collect and analyze patient information, either from talking to our patients and their family members, talking to other healthcare professionals, and then using our computer system. I design drug regimens and monitoring plans and discuss those with the rest of the healthcare team. I do medication reconciliation and patient counseling. So when a patient comes into the ER, I'm actually in charge of, we have a med rec tech program. So we have pharmacy technicians that will talk to the patient, they'll talk to their family, and they'll call their pharmacy, and they'll figure out what medications the patient was on at home. And then we'll compile a list so that way the provider can order all of their home medications inpatient, or if there's an issue, we can figure out if that issue was caused by the medications they were on at home. I also provide drug information to patients and other clinicians, and then assist with therapeutic drug monitoring and pharmacokinetic dosing, which we'll talk a little bit about today. So in the ICU, we have a 16-bed ICU and CCU. This is comprised of intensive care patients. We get cardiac patients. We have a very robust cath lab. So after they have a procedure, they will come to us. And then also surgical ICU patients. It's a little different. Most larger hospitals have specialized ICUs, but we get everything. We have daily rounds at 10:30. So these rounds include me, an attending physician, the nurse for that patient, a registered dietitian, a respiratory therapist, and then therapy services, so physical therapy, occupational therapy, speech therapy, and social work. And what we do is we all get together in a group at 10:30 and we walk room to room and we discuss the patient in depth. And each of us has time to speak. We kind of do some problem solving and all have our input heard, which is really nice. And then usually this group also includes learners. So we are not a teaching hospital, but we do get medical students, we get respiratory therapy students, And then we get tons of pharmacy students, and we have a residency program. So I pretty much 10 months out of the year have learners with me. I also take high school students that get to shadow pharmacists, so they will be a part of these rounds as well. The ER component is a little bit different. So we have 33 rooms in our ER. But that being said, we are very busy, and those rooms can be doubled or tripled. So we usually have way more than 33 patients. We also have something called Super Track, which is a newer kind of idea in our area. So they're actually recliners that the patients are in. So if you come in and you're not a very critical patient, you may sit in those recliners versus being in a room, and that allows us to see more patients. And then I respond to all critical events. So any stroke alerts, any cardiac or respiratory arrests, STEMIs, and traumas. So some of these they call overhead in our hospital, and the rest I have a pager, or they'll call me throughout the day to let me know that these patients are coming in. So every day is completely different because you never know what's going to happen to the patients. So the only thing that is set in stone is that I attend those rounds at 10:30. That being said, if they call a code or something during that time, I will leave rounds. So my rule is pretty much the sickest patient in the hospital gets my attention at that moment. And then either before, after, or during rounds, I deliver meds to beds. So we actually have a Finley graduate that runs our meds to beds program at UH Portage. So when they're discharged from the hospital, we fill their medications, their new prescriptions that are getting sent home with, and deliver them to the patient so that when they leave the hospital, they don't have to stop by a pharmacy. And I provide counseling to them. I help them with, we'll get them pill boxes, anything to help increase their chances of taking those medications and being adherent. And then, like I said, I'll go to all those codes and critical events throughout the hospital. And then I try to spend my afternoon in the ER. So I try to split my day about half and half, but it just depends on what's going on. So the first thing we're going to talk about is not critical care specific. All of our pharmacists do this, but it's something I do a lot, the vancomycin RPH to dose. So pharmacy-led vancomycin dosing services, they're actually recommended by the IDSA and the Society for Healthcare Epidemiology in America. They've shown that there's better outcomes when pharmacists are involved. So the goals of a program such as this, which my institution utilizes, is to optimize dosing for these patients. So just to make sure that they're on proper dosing, to ensure that we're safely using vancomycin and that someone's following that patient on a daily basis, and then to reduce costs. So as you'll see in the case that we're going to do, we try to get vancomycin stopped as soon as possible. Whereas the provider, they may order vancomycin when the patient's admitted to the service, and they may not have as much time to follow that patient up daily. These patients will have a pharmacist monitoring them pretty much 24/7, which is a great benefit. So in order to do this, the provider places a consult. So we have this pharmacy to dose vancomycin order that they order in the EMR, and that automatically initiates a consult to pharmacy. So we get a printout in pharmacy that says we've been consulted, and they get thrown on this consult list, which we'll talk about. The provider chooses the indication and the goal trough for the vancomycin, but if the pharmacist disagrees or if that changes throughout the course of treatment, the pharmacist is able to change that, and we document all of that and talk to the provider. So things like skin and soft tissue infections, where we may use a lower trough goal. If we find out maybe on day 2 or day 3 of the hospitalization that there's actually bone involvement, the pharmacist will increase that trough. And likewise, if we initially thought it was a more severe infection and it turns out to not be, we will decrease that trough. So we do have a lot of leadway. This consult gives us privilege to do whatever we need to do. And we try to keep the communication with the provider as open as possible because we want them to encourage them to keep utilizing pharmacy. We are very lucky at my hospital. None of the physicians dose vancomycin. They would rather pharmacy do it. So you will never see a physician in my hospital dosing vanco. They really trust us, which is nice. So as soon as we get that consult, we'll start dosing. So we will order dosing, which we'll go through in the example. But then to kind of increase that communication, so we do have a service where I can essentially text the provider through this program that we have, But we also put a note in the EMR. So it's this therapeutic drug monitoring, and that lays out our indication, our goal trough. It has all the statistics on the patient, has all their cultures, and it kind of outlines the plan that pharmacy is going for. And that gets updated every few days so that the provider, if they have any questions, they can go in the note section and see what we're doing. And then we also have an internal note. So pharmacy services at my hospital are 24/7. So in between shifts, this allows a pharmacist, let's say, I worked last night, the pharmacist coming in the morning can see this internal note and see what my plans were for the patient. And it just provides really good handoff so we don't miss anything. So that consult list that I alluded to, it automatically pulls all patients that have that pharmacy to dose vancomycin order. And all of the pharmacists have this list. So daily, at least once during your shift, the expectation is that you review all of those patients. And again, you can see when trough levels are due because of those internal notes. So that'll kind of flag which patients you should look at first. Critical care, my job is to look at any of the critical care patients. So any patients in the ICU or ER that are ordered vancomycin, I'm responsible for. A pharmacist will daily review their renal function. And if there's not a serum creatinine ordered within the last 48 hours, the pharmacist can automatically order that. So we can order some lab work. We will also order those trough levels and the random levels. And then those notes that are in that the provider can see, we will put a new note in for every level result. Anytime we change dosing, anytime we discontinue dosing, so that way the provider knows, like, hey, pharmacy is not looking at this patient anymore. Vancomycin has been stopped, so that way they're not thinking we're still monitoring. And then every 3 days, if there's no changes to vancomycin dosing, we'll put a note just like, hey, we're still following this patient, everything looks good, and we're still here. And that way everyone is on board, and the nurses can see those as well. And then when that discontinuation order comes through, so whether we cannot automatically discontinue vanco, so we'll talk to the provider once we get approval to discontinue. We'll discontinue that consult. It'll automatically discontinue every single vancomycin order on their chart, and then they'll automatically get pulled from that list. So now we're going to look at an example policy and apply that to a patient case. So I am going to make you interact with me a little bit to make it a little more fun. So we have patient AB, who's a 55-year-old female that comes into the ER. She has shortness of breath, cough, and a fever. So 3 days ago, she was at another hospital and she tested positive for COVID. And a chest x-ray done at our hospital shows that she has worsening pneumonia. I put her height, weight, and serum creatinine, but you don't need to remember this. So the ER provider orders vancomycin RPH to dose with an indication of pneumonia, which gives them an automatic goal trough of 15 to 20. And this is a very common scenario that we see. So our example policy, which is what we use in my hospital. So if there's a patient that has a potential severe infection or septic shock, you give them a loading dose. So any patients that you're concerned about MRSA, if they have CNS infection, pneumonia, endocarditis, or bacteremia, they need a loading dose. Also, if they're in septic shock or on pressors, regardless of that indication, they need a loading dose. So patient AB would get a loading dose because she's being seen for pneumonia. And as you can see here, this policy will automatically tell you, based on weight, what loading dose to give. That being said, we don't always follow this policy 100%, and our providers are okay with that. So if there's a situation in which we feel that a patient doesn't fall within one of these categories, we do have the opportunity to change, and we will communicate in real time that with the provider and get approval. And then we have our empiric dosing. So after that loading dose, you'll do a maintenance dose, and that's based on actual body weight. Our policy is nice, it breaks it down. So we automatically round to the nearest 250 milligrams because of the products that we stock, and it just makes it easier for everyone. So all of our vancomycin comes as a premix, or we snap a vial to a bag. So we're not having to make odd doses. And then it breaks down in hemodialysis, our dosing, because those patients are a little bit trickier. So what loading dose would you order for AB? I'll give you a second. If anyone wants to chime in, they can, or if they want to put in the chat, or I can also just go through. It's up to you.
Yes, please. Now you can put it on the chat box, your response, please. Lindsay, can you tell again the weight of the patient? Probably people forgot.
Yes, so she's 57.6 kilos. And I'll pull up our policy.
I got one response here.
One second. Yes, so 1,500 milligrams. So this patient is a pretty cut and dry. We're treating pneumonia. She's relatively young. Weight falls within that category. So she's someone that I would follow the policy for. It's not common that we go off of policy, but I just wanted you to be aware of that.
Sure. Very good.
Yes, so as you can see, she falls within that category, so she would get 1,500 milligrams. And then what maintenance dose would you order for her? So again, she's in that 55 to 64, 57 kilos, I believe we said. So we have a gram, 1,000 milligrams. So she would actually get the 750 milligrams. So she falls within that 41 to 59. She was 57 kilos. So she would get a loading dose of 1,500 milligrams and then a maintenance dose of 750 milligrams.
Okay.
So we would place that order, so we'd place our loading dose, but what about frequency? So the frequency is based on their creatinine clearance, and we use the Cockcroft-Gault. We'll actually talk about in the renal dosing section. We have a calculator that does all of this for you, but you can calculate using the equation that you're taught in school. We use a calculator because it's standardized, so it's approved for our policy. We're going to use ideal body weight unless the actual body weight is less than the ideal, then you're going to use the actual, you're going to use ideal and less. And then if their actual is greater than 40% of their ideal, we use adjusted. And the calculator we have accounts for all of this. And then we have this nice table that breaks down based on the patient's creatinine clearance, what frequency you would order. So if I give you that her creatinine clearance is 68.1, what frequency would you choose? And this one's a little bit of a trick.
We have one response here, Nancy.
Yes, you see that. So yes, I did not trick you. Good. Every 12 hours. So the answer is A. So this one's a little tricky, and I could see why you would say 8 hours. And this gets missed a lot. So as you can see, there's this little notation next to this. So that every 8-hour dosing, we only give to patients that are less than 40 years old, which I should have flipped back. She was 55 with a normal renal function, so greater than 90. And this is just because we've seen both in our institution and within studies, when you dose patients that are older than that with worsening renal function, you're more likely to have supratherapeutic troughs and AKIs or kidney injuries. So we're a little more conservative in doing every 12 hours. So something else, which is not an issue in this case, so previous Vanco dosing history, and this is where those MedRec techs and that MedRec program are very important. So any patient that's previously received vancomycin, we should look at that. So if they were in our hospital, all of these patients are automatically saved in a folder. So if the patient was in within the last year and received vancomycin, I can pull up their dosing sheet and see how they responded to the dosing that we picked. And let's say we followed this policy and she was super therapeutic. That's a case where I might go off policy and reduce her dosing a little bit. We also look at patients that have recently received vanco. So for those MedRec techs, a lot of patients in nursing homes in our area will actually get vancomycin. So if they've been getting vanco, we wouldn't need to load them. We would want to check a random level and see how they're doing, and then dose based off of that. And then that therapeutic drug monitoring we talked about. So we have to time out our levels to get an accurate trough. So depending on their renal function, that tells us when to time the level. So if they're every 8 to 12 hours, it's before the 4th dose. If they're every 24 hours, so that's your frequency of your vanco, it's before the 3rd dose. That 3rd dose, they're not at steady state yet. So we wouldn't expect that trough to be 100% where we want it, but it gives us an idea of where the patient's headed. And then unfortunately, in critical care, a lot of my patients don't have great renal function. They have acute kidney injury. It's just unfortunately part of what's expected when they're super sick. So a lot of my patients are random levels. So they'll get a one-time dose, we'll check a level in 24 hours, and then we'll order another dose. And those patients are off policy, and I'm pretty lucky. The 3 providers that I work with in the ICU, they're aware of that and they're okay with that. But that's just, again, the nature of those critical patients. And then hemodialysis, we just get a level with AM labs before their dialysis sessions. So if AB's renal function remains stable, when would you check a trough? Again, she's on that every 12-hour dosing. I'll flip back so you can see the options. So we know she's not getting hemodialysis and she has stable renal function. So she would not be by levels, which would be your 24 to 48 hours. So your options then would be either the 3rd or the 4th dose. So it's going to be 30 minutes before the 4th dose. And that is, so we would enter, pharmacy enters that. We try to make it 30 minutes before the dose because that gives time for the nurse to draw that lab, send it to our inpatient lab, it to result, and then for us to read it, hopefully before they hang that next dose. If they hang the next dose and we need to make an adjustment, that's okay. We'll make an adjustment after. We also don't want the nurse to delay therapy waiting for that level, just because these patients are very sick. So again, she would be before that 4th dose. This is where she falls. So then as the pharmacist, I would order the loading dose. So she'd get 1,500 milligrams IV once. And because that's our loading dose, she's in the ER, that would be stat. So I would not pick like a scheduled time for that. The nurse would hang it as soon as I tube that drug down to them. I would then order a maintenance dose of 750 milligrams every 12 hours. And I would want to order a trough level 30 minutes before the 4th dose. So I would verify my loading dose, and then I would wait until they give that loading dose and look at what time the nurse gave it. And then I would be able to actually time out that maintenance dose order. So let's say they gave the dose at 10 a.m. this morning, I could go in and schedule that maintenance dose to start at 10 p.m. tonight. And that's how I would know how to time out that trough. And then I would also order an MRSA PCR, which we'll talk about. So this is something that I actually didn't know was unique to my hospital, but more hospitals are starting to do this. So at my institution, only the pharmacist can order an MRSA PCR. And that's because they get overutilized. So it takes about an hour to result. The nurse will swab the patient's nose and send that to inpatient lab. It's very similar to like a COVID or a flu swab. The PCR is run inpatient, like in our own lab, but the provider can order a screen, and that screen is different than the PCR. It's actually sent to our main campus. So it takes about 2 to 3 days to get that result back. And the reason they don't want everyone to be able to order that PCR that comes back so fast is because a lot of patients, me included working in a hospital, I would probably test positive for MRSA in my nose. A lot of patients are colonized, but when we have a patient with pneumonia, if they have MRSA in their nose, it is likely that they have MRSA pneumonia. If that MRSA is negative, the PCR, that means it is unlikely MRSA pneumonia, and we could DC the vancomycin. You will see some providers will try to order an MRSA PCR for other conditions, so like bacteremia, skin and soft tissue, and it's not a great indicator of that. It's really just for pneumonia. So that's why they've kind of only allowed pharmacists to order this. It's just a cost savings and to make sure it's being utilized correctly. So also very common. So this patient, her MRSA resulted as not detected, which is surprising. So patients that are more likely, like I said, me working in a hospital, I would probably test positive. Patients that come from like group homes or long-term care facilities are more likely to test positive. Or this patient, we said she had previously been hospitalized. She would also be more likely to test positive, that colonization. So fortunately, she only got that vancomycin loading dose that was given in ER. So I would contact the provider and I would recommend stopping vancomycin because she is not MRSA positive. And then the provider accepts the recommendation, which is great. You just did stewardship and you dosed your vanco and you provided a cost savings to the patient and the institution, which is great. So this happens a lot for us, especially a lot of pneumonia patients this time of year. And then had we not stopped vancomycin, so this talks about dosing adjustments. So again, that goal trough of 15 to 20, that's your more severe infections. Goal trough of 10 to 15, the only cases we really use that in is skin and soft tissue where there's no bone involvement, and then UTIs that aren't complicated. And then this would tell you, depending on your goal trough and what that level results as, what to do with your dose. And this part, I will say, we go off policy quite a bit because this isn't perfect. Not every patient falls within this, but it gives you an idea of what to do with dosing. And this whole policy is something we have printed out. So our staff pharmacists have this next to them as they're staffing. And again, like you saw in this case, you can kind of just go through point by point and it helps you know what to do, which is very nice. And then I just also wanted to include this for your reference. So hemodialysis patients, which I also have a lot of dialysis patients on my unit, they're a little different. So you just get a pre-dialysis level. So the patient would still get a loading dose, and then we would check their level after their first dialysis, so before their second dialysis session. And these patients, you can get a little bit higher of a trough, so up to 25. That doesn't sound great, but their kidneys aren't functioning, so you're not as worried about that risk of harming the kidneys. And because it's up to 25, once they have dialysis, you'll get a little bit of clearance in that. They'll even out to about 20. So. And now we're going to move on to renal dosing adjustment. So this is something that I do every day and all of our pharmacists do. So the staff pharmacist that's verifying all the orders for our hospital, they will screen all new medications for appropriate dosing. So when the patient is first admitted and they got all their admission orders, and then throughout their stay, every time there's a new order, the pharmacist is looking at this. Like I mentioned, they use a standardized calculator because that's what our policy is set off of. So if the drug is in the policy and you use that creatinine clearance calculator, the pharmacist can automatically change the dosing without talking to the provider. If the drug is not in the policy, then the pharmacist will reach out to the provider and make a recommendation. And again, I am super fortunate. Pretty much all of our providers love pharmacy, and it is very infrequent that you will get told no. And then the clinical specialist. So in my role, we screen the orders daily. So again, patients in the critical care setting have very rapidly changing renal function. So there'll be days where it seems like every single day I'm adjusting the drugs back and forth, but that's pretty normal. So this is that calculator I was talking about. I just wanted to provide this as an example. So this is actually in an Excel sheet, and all the pharmacists have it available to them. And when you type in your height, your weight, your age, gender, and your serum creatinine, it'll automatically calculate all of this for you. So again, easiest way to remember it, so we'll use the ideal body weight. Unless there's an adjusted, this calculator will actually not show you the adjusted if you're not supposed to use it. So it would be blank there. So it's kind of foolproof. You just use the lowest number on this list, essentially, if you want to think about it that way. And then there's some nice conversion tools, but this is just a really nice tool that all pharmacists have available to them at my institution that was built by pharmacy. And then the example policy that we use. So this is a little overwhelming. I don't expect you to know any of this, but I just want to show you what it looks like. So this again is also printed out and we have it on our computers. These are all the drugs that you can automatically adjust without getting a provider's approval. So as you'll see, you have your drug names, they're all alphabetical, your creatinine clearance, and then what dosing to use. Some of these have two categories because it's depending on the type of infection. So like if we go down here to cefepime, your more mild infections will get lower dosing than like your CNS and your pneumonias. So you also are looking at indication on this as well. And again, I realize this is very overwhelming, but it's just nice to see what we utilize. And it's a 4-page document. There's lots of things, like some of these will use actual body weight when using creatinine clearance. You have to let the doctor know for some of these, the INR. For instance, like Pradaxa, you can't increase without contacting the provider, just to let them know. But it has everything in here. So it's pretty nice to be able to just reference this document. Some of these, it'll even include like your Lovenox for STEMI, like when you should use a bolus, when you should not. And we'll kind of follow a lot of my patients, they'll start out with higher dosing on these indications, and then we may decrease as we're able to, just as we learn more about the patient and the patient becomes more stable. And then one that comes up a lot is we use Zosyn extended infusion. So you can use conventional dosing, which is every 6 hours, and it's every 6 to 8 hours, sorry, and it's run over 30 minutes. But you can also use Zosyn extended infusion. So instead of over 30 minutes, you're running that drug over 4 hours. So the first dose in your patient that is septic or being treated for the first time, you'll use a conventional infusion of Zosyn over 30 minutes because you want to get that concentration up. You want to get that drug to the patient fast. And then after that, we'll switch to extended infusion over 4 hours. The benefit of this, there's no real benefit for treating the infection. They're still getting the same outcome, but it's a cost savings to the hospital, and it's one less drug that the patient has to get that day. So they're getting, if you do that every 30 minutes, they end up getting an extra dose every day. So we're waking the patient up overnight to hang this IV. We're using the cost of another drug when we could use less frequent dosing and run it a little bit longer, and you get that benefit to the patient and the hospital. But there's some instances like with Vanco, so Zosyn and Vanco, you cannot run together through the same line. So sometimes we'll use the conventional dosing if dosing overlaps, and pharmacy again manages all that. We'll kind of move things around and change dosing to help them make sure we have enough lines and that we're not giving medications that can't be run together. But that's probably the one that I use the most off this list is Zosyn. So another case, so we have a 44-year-old female who has a history of non-valvular AFib, who's admitted to the ICU. This actually recently happened. So she takes rivaroxaban 20 milligrams daily at home, and this was continued inpatient after our MedRec techs did the MedRec. So on day 4 of her hospitalization, she develops an acute kidney injury, and her creatinine clearance decreases from 78 to 37. So what should we do? So this is a case where I would know that, because I have this list kind of memorized because I look at it so much, that Xarelto is in our policy and it's renally dosed. So she now falls into that 15 milligrams daily. So I would decrease the dose, and this is something that I can automatically do without letting the provider know. That being said, because it is an anticoagulant, I would let the doctor know, especially if the patient's going to be discharged. I wouldn't want her to be discharged on the wrong dose. So this is a case where I let the provider know, hey, I decreased the dose. She can be increased once she leaves, as long as that resolves. So I can automatically do it, but we do keep them in the loop. And then another case that recently happened. So we have a 67-year-old male who was admitted to our step-down unit. So step-down is where our patients go after the ICU or before the ICU. It's a step-down in care. He recently started ranolazine 1,000 milligrams twice daily at home. And this was continued inpatient after he had a MedRec done. Several days later, they called a rapid response overhead that I attended, and he was hypotensive, he was confused, he was dizzy, and he had a really bad headache. A quick review, so whenever I get called to these situations, I immediately pull up the patient med list and see if there's anything that could have caused that rapid response being called. So any guesses, which we're talking about renal dosing, so I bet you can guess. Dosing was not appropriate. So this is a drug that is not on our list to automatically adjust, but could have been contributing to the patient's case as to why that rapid was called. So his creatinine clearance was 22.7, and he was on too high of a dose. So as you can see, this is off LexiComp, but in patients that have a creatinine clearance less than 30, you have to use ranolazine with extreme caution. So you can have neurological side effects, and you should really start at 500 milligrams once daily and only increase to 500 milligrams twice daily. So he had been started on this at an outside facility that did not do labs, didn't see his creatinine clearance. They just started a gram twice a day, and he was having side effects from that accumulation. So this was a case where immediately we held the drug, and then we reduced that dosing, and we made sure that on discharge, he got a new prescription for that 500 milligrams twice daily and knew not to go back to that a gram twice a day. And then just quickly, I just wanted to talk about other dosing interventions that I frequently make on my service. So QTC prolongation. So I look at any medications on the patient's profile that can prolong their QTC. And then I'm able to see their most recent EKG. A lot of times, like yesterday, I had a patient that I recommended repeating the EKG. All of her QTCs had been normal except for the most recent, and she was on sertraline, so I didn't want her to continue on that if her QTC was increasing. So I'll follow that very closely and recommend, usually we're holding those medications rather than reducing them. The anticoagulants and the antiplatelets. So I very closely monitor hemoglobin and platelet counts and recommend holding those medications if needed. I think most recently I had a patient that ended up being a bleed, but very early on before the hemoglobin dropped, the platelets were dropping. So we held their prophylactic heparin. So that's something I monitor daily and recommend. And then COVID patients. So in the beginning of COVID, we were checking all patients' D-dimers, and we were putting them on therapeutic anticoagulation in the hospital if their D-dimer was elevated above a certain threshold. We quickly found out, as did most of the country, and studies are now coming out, that our critical patients were more likely to bleed. So if a patient is in the ICU, we automatically do not do therapeutic anticoagulation, no matter what that D-dimer is. If they're up on one of our other floors, we sometimes do therapeutic anticoagulation, but I'm frequently recommending to go back to prophylactic dosing. This is something newer and the data keeps emerging. So the providers are just used to going to that old order set. So this is something I watch pretty closely because we don't want to have any bleeds that will complicate their stay. So liver function, so I'll look at the LFTs. A lot of times we'll hold patients statins while they're in the ICU. Statins are based off a 10-year risk score, so holding it for a couple days while they're in an ICU isn't the biggest deal, and we don't want to have their liver function continue to increase, but this is something we'll frequently do. Also blood glucose, so we have a higher threshold in the ICU. Our goal is 140 to 180. So I'll recommend increasing corrective scale insulin if they're consistently above 180. And then if needed, sometimes we need to start these patients on basal insulin. A lot of our patients are on steroids, which will increase their glucose and just being very sick. So that's something I very frequently monitor. And then just electrolytes in general. So potassium, magnesium, and phosphorus. So I'll watch those daily, recommend initiating replacement and what dose to do that at. A lot of our patients come in with hyperkalemia, so we have a K cocktail. They'll get some regular insulin, some albuterol, they'll get a potassium binder, some dextrose for that insulin, so I make sure they're appropriately ordering those K cocktails. And then also monitoring sodium closely, so that's something that we have to worry about in our patients. But those are all things I monitor on a daily basis and recommend dosing adjustments based off of. So what questions do you guys have for me? I know that's a lot.
I think, Lindsay, there's somebody who has asked, what is the drug of choice in elevated dimer patient?
Yeah, so it honestly just depends. We're using a lot of heparin drips. Either heparin or Lovenox are what we use. Benefits, Lovenox is usually twice a day, less frequent injections. The heparin requires a lot more frequent monitoring on the nurse's part. So we will try to use Lovenox if we're able to. But in our more unstable patients, we'll use heparin just because it's a little bit faster off and on. And we can stop that immediately if we need to. So I'd say up on the floor, we use Lovenox more. If it's a patient that we have to use a heparin in the ICU, we'll use heparin.
Okay. Lindsay, you can do the stop screen share now. So stop the screen share so everybody comes away.
There you go.
So folks, anybody else has any questions for her before she leaves? And then I will take 10-15 minutes to put together what we can do with this information. Ask to unmute and please ask your question, please. I give you 2 minutes, okay? If you know questions, just like any other student in my class, there's never a question. I'm not sure whether I was very clear or I was not clear. Okay, Rupesh, go ahead,
Hello?
please. Yeah.
Sir, if patient QTC is almost prolonged 420 above, so we are mostly using that levofloxacin, clarithromycin drugs. Is there any precautions that we have to stop that one?
Sorry, you cut out a little bit. I think was the question.
Yeah,
if they're
please, type in the question also because I think the voice is.
So please hold on a second.
Okay, sure.
Actually, I'm typing that one.
Okay. Yeah, here is a question there.
Yeah, so if they're above 420, we just monitor them closely. So I'll keep into consideration how many prolonging drugs they're on. Obviously, if they're on more than one, their chances are higher of becoming prolonged. Really, 500 is about where our cutoff is. So we'll let patients get pretty close. They're on continuous cardiac monitoring in the ICU, which is a benefit. So we'll let them get a little higher than we normally would. We do see a lot of Zofran. We'll usually switch to Phenergan. Levofloxacin, we actually don't use a whole lot of. The fluoroquinolones in general, I feel like pharmacy school here kind of puts the fear in you. They're not as good as they used to be. Like we're getting resistance, we're getting a lot of side effects. So usually if you recommend a fluoroquinolone in our hospitals, it doesn't go over well. But we still do see that, and that is a real consideration. That's a patient that if I needed to use Levaquin, I would probably switch them to Phenergan or another medication, and then I would recommend a repeat QTC in a few days.
It's interesting. Go ahead. When I was practicing as a pharmacist, there were a lot of levofloxacin floating around. I think things have changed. And
Yes, they have.
Long time since they really did anything like this. Okay. Any other questions?
One of our providers that's been practicing for a while, he always laughs when he orders it. And he's like, I'm going to stress pharmacy out with this order. And I'm like, yes, you are. But sometimes we need to use it.
Madam, and what are the considerations for D-dimer elevation? So most of the times we used to go for heparin, like anticoagulants, heparin and enoxaparin, fondaparinux. And so as you said that there is a patient with renal, so LRTA condition, you have chosen rivaroxaban, right? 20 mg.
So that patient was for non-valvular AFib. Yeah, so that was a home medication that we were adjusting. D-dimer elevation, so we do have a policy for those patients on which drugs you can use, which dosing, which monitoring. We'll get heparin assays and we'll get Lovenox assays as well, which is something we don't normally do. And then there is an option for our COVID patients with elevated D-dimer to send them home on anticoagulation, but we don't frequently do that. Rivaroxaban is an option for that. But that honestly is more of our internal med pharmacist. I don't do a whole lot of that because not many of my patients get discharged directly from the ICU. But yes, that patient was non-COVID positive. That was a home medication that we were adjusting.
Okay, ma'am. Thank you so much for the answer.
Yeah.
And I have one more question, ma'am. So actually, so most of the people and so most of the lower respiratory tract infections here, some of the doctors are advising only single antibiotics doesn't do much regarding the infection control. So we have to go for at least 2 antibiotics, because in India, this is a company with tropical diseases also we have to consider, because we don't know how the patient is affected by the infection. So how much it is going to benefit the patient on your scenario?
So you're talking about single versus like double coverage?
Yeah.
Yeah, so most of our patients, so I only talked about Vanco, but we pretty much always have 2 drugs on. I kind of joke that it's our least favorite, but they tend to put Vanco and Zosyn on everyone when they're admitted, because those are our 2 kind of big guns for a lot of the infections we see around us. And that's why I talked about that MRSA PCR, because pharmacy will try to de-escalate as soon as possible. Because most patients off the street here don't automatically need Vanco and Zosyn. But most patients are on 2 to 3 antibiotics. We pretty much always make sure we see a lot of atypicals, so we make sure we have atypical coverage on. And then a lot of patients too will get 2 to 3 antibiotics, like 1 dose in the ER. And then when they're admitted, sometimes they're admitted on those exact antibiotics, or they'll try to de-escalate if they can after getting some patient history. But same kind of thing, we're usually using at least 2 antibiotics. And that's why we have actually a stewardship pharmacist that reviews all of that as well.
Okay, ma'am. And one more thing, madam. So how much do you have access, how much do you use the tetracycline based drugs for the patient in pneumonia conditions?
Tetracyclines, we actually use a lot. So we use either, I mean, our main 2 are azithromycin or doxy. Probably our #1 intervention for pharmacy is all the docs. I think our pneumonia order set automatically defaults to azithromycin, and we'll check the QTC. Most of our patients don't qualify for azithromycin based off their QTC, so we'll recommend doxycycline.
Recording in progress.
And that's, like I said, probably our #1 intervention in pharmacy in general. So at least in the beginning, they'll at least get 1 of those drugs.
Okay. Very good. Lindsay, first, thank you very much for sharing this Saturday after morning with us. And I certainly hope that, you found it useful information. You get to see, actually, Indian situation is quite different. We do use a lot more antibiotics, and those type of challenges are there. But I was just looking at the other day in my class I teach. When Britishers left India, we had 11% of the population which was educated in 1947, and now it is 75%. And there are states in India where the lifespan is better than average lifespan in America.
Mhm.
We have been actually the last after COVID, our lifespan has decreased by 0.9 months. So we have a big challenge here in America, and challenges in India is like developing country, resources are limited and everybody doesn't get. We do have different models. People who can go to a doctor and afford a treatment, they get the best treatment. And those who cannot, they just go to a scam artist and they will get whatever they can from there. So but at the same time, things are changing, it's improving. And as you can see, I don't think I can get 16 students to come on a volunteer seminar in University of Finlay on a Saturday morning or evening to have to come. So there are a lot of motivated students, and your sharing with the information is absolutely great. Thank you very much.
Yeah, thank you. And thank you everyone for joining. I appreciate it.
Hopefully Kale will bring you one day to India. You tell him that, okay? You have to go. Okay. Take care and goodbye. Yeah. Folks,
thank
just
you.
stay around. I have got a few questions for you. Goodbye. So, well, I certainly hope that all of you, you can unmute yourself now because we'll just have a two-way conversation. Hope you found the information useful. If you did, use what is called, give me a thumbs up or some sort of sign in your chat box or in the picture here. So I know that this was a useful session for you. Thank you. So now I'm not sure where are all of you from. So are you all from BMMSH Hospital or where do you practice? We can open up and talk. So can anybody respond here?
Sir, I can see the list. We are just around 4 to 5 members from BMMSH.
Okay.
And rest are from different part of the India, I believe.
Oh, wonderful. So can you just tell me those who are from different part of India, just show me where they are, just type in the message here, where they are from, so that everybody can figure it out.
We had 143 registrations so far, but we could not
No,
get
that's fine. I'm just concerned about just get the information from those who are there. Rupesh, he asked a couple of questions. Ahmedabad, Hyderabad. Okay. So now this is what my folks, the reason I ask my students who are practicing in interesting environment, who are doing a good job, to share the information is that it's finally translated into some form in Indian scenario. So, and I also have a publication called Global Health Online, where I can publish articles of what things are happening in your hospital, in our country, in India. Okay, so if any of you really want to improve your career, you better have to improve your communication. That is, you have to be able to talk, you have to be able to write. And only when we write and share the information with others, then people know what's happening. And somebody may recognize your talent and your skill and get you a better job or a better position. So having said that, I've got a few questions for you, which you can think about it. And I will write my email address here and you can respond to me later at finlay.edu. Please note it down. So I think, do any of your hospitals use vancomycin? So say yes or no. All of you can respond, please. Yes or no? Okay, the question was no. Okay, there's only 2 answers. What about the other remaining 10 people here? Okay, so based on this, if you have a vancomycin, do you, those like Shivaling, tell me, they do any type of adjustment on Asim? anybody does the adjustment for the Vanco dosing, or who does it? Is it the physician or the pharmacist?
Yes, sir. In our BMSS, along with physician, we had a discussion with main critical care consultant and decided the dose to administer. Sir.
Okay, so I mean, so basically, so who, like in the regular scheme, is it the physician who make the decision on a routine basis how much to be given?
No, sir. Actually, they make us to calculate the dose based on the patient creatinine clearance and
Okay,
this
and
one,
then,
sir.
okay.
Yes, sir.
So now, so basically, if I mean this video, I will be going to put the Zoom link for this presentation, so you can see. So do you have? I mean, like now you calculate on thing. You do? Can you make it? I'm sure there are apps available for calculating it. Do you ever use an app to calculate the dosing?
Yeah, sir. One app called like MD Calcel.
Okay, good. So you have. So if there is any difference between what she does or all the other drugs, list of drugs which requires a dosing adjustment, which she made on the bottom, which do you do all of them or some of them, or exactly? So there are some differences, and something can be protocol or policy is there, then it becomes easy to follow. So anyway, so those are the things one can learn, and if you don't have it, you can develop that for your hospital or setting, and that makes it much more easier, and you get recognized as somebody who is interested in improving the patient outcome and all that purposes. So that's all I have. So if anybody is wanting to publish an article, this is a great way for you to send email to me, and I can guide you on how to publish for Global Health Online. I edit it, make sure the English and all that looks good. And on an average, the articles we are publishing are getting about 15 to 20 downloads per month for literally for next few years. So that makes your name more recognizable, and you have something to document which you have finished, and a scientific article you have done after your PharmD during your doing education, doing a residency and all that. So any of you have any question for me? Okay. Well, if you have no questions, I wish you thank you for joining me in this session. This is the last of the session with BMMSH. I wish you all a good luck. And if any of you want to contact me, get some more information or pursue some projects, I'll be happy to help you. I've got 3 students from Andhra coming with Vignan College for all presenting a poster in both my symposium for scholarship and creativity at University of Finlay, as well as at the American Pharmacists Association meeting. So my ambition or desire is to improve pharmacy practice in India by providing any opportunity I can personally to students in India to learn more about it and apply that in real life in their own practice. Thank you and have a great day.
Thank you, sir.
Welcome.